Can you see my screen?
No, doctor.
Can you see my screen now?
Yes.
Okay, shall we start? Okay, today we're going to talk about the class 3 malocclusion. So previously we finished with the class 1 and class 2 malocclusion. And today we come to the final series of the malocclusion, which is the class 3. So class 3 malocclusion, it just means the lower teeth are bit protruding or they are in the reverse spine. So what's the learning outcome today? So the learning outcome today, at the end of lecture, you should be able to explain the incisor and the molar classification of the class 3 malocclusion and its clinical features as well. Then you should be able to explain the etiology of the class 3 malocclusion. Then you should be able to differentiate between the type of class 3 malocclusion. There's so many types of malocclusion, class 3. Then we're going to explain it one by one. And you should be able to explain the treatment approach of the class 3 malocclusion at the various stage of the treatment. So when the patient is growing or they are teenagers, and it will be different from the adult stage, the treatment approach. So what's the content of today's lecture? So first we're going to go through the introduction of class 3 malocclusion, etiology, then the features of the class 3 malocclusion, then treatment planning, then how we're going to treat it, or the management options. So introductions, the malocclusion that's really easy to identify, but it's often very difficult to treat, is the class 3 malocclusion. So when you see the patient have a longer lower jaw or the face in the concave profile, then it's very easy to identify. But in orthodontic approach, it's always difficult to treat the class 3 malocclusion. This condition represents a prenormalcy where the mandible is in the mesial relationship to the upper arch. It just means the lower jaw is sticking out a little bit compared to the upper jaw. It means the mandible is longer than the maxilla. According to the angle, a class 3 malocclusions or molar relationship refer to a condition where the mesial buccal cups of the upper first molar occlude between the mandibular first and the second molar. So this one I think we also discussed before from the last or the previous lectures. So what's the etiology for class 3 malocclusions? A true class 3 malocclusion that exhibits the underlying skeletal imbalance is usually inherited. So it means the class 3 malocclusion usually is due to the jaw relationship is not matching. So it can be due to the upper jaw is too short or the lower jaw is too long. And this one usually genetic. It means it passed down through the generations. Sometimes you might skip one generation. It means your kid won't have it. Then maybe it passed down the next generations and after that. So they're usually in the family gene. So you look at the mother's side or father's side, then usually one of them can be a class 3 skeletal pattern. So and they're very strong genetic basis. So like I say, it will pass down through the generations. So sometimes it will become big recessive for 1 or 2 generations. Then after that, they might reappear again. So occlusal prematuries or enlarged adenoid other causes, can be other causes. So sometimes you can have a premature contact. It means the incisor have a premature contact and the mandible slide forward, or we call it displacement or functional shift. This can be caused a class 3 malocclusion also. Sometimes you have an enlarged adenoid, and you have a nose blockage or sinus problem. Then patient tend to breathe through the mouth. Then this kind of patient can have a class 3 skeletal pattern. So there's other causes also, but mainly genetic. So etiology can be skeletal pattern, which is a prognathic mandible. It means the lower jaw is too long. Or retrognathictic maxilla, it means the upper jaw is too short. So increased mandibular length, we call it prognathic. Decreased maxillary length, we call it retrognathictic. Can be a big combination of both. It can be short mandible, short maxilla. then long mandible, can be combination of both. Then soft tissue, the dental alveolar compensations. Because this kind of patient usually have a reverse overjet, it means the lips a bit difficult to achieve the competency. So in order to achieve the competent lips, then usually patient will try to bring the lower lip against upper lips. Then means we have to recline the lower incisor and procline the upper incisor. This one I call it dental alveolar compensations. So dental factor, then usually these patients, this kind of patient, castry malocclusion, they have a narrow upper arch, which is a broad lower arch. Sorry, this is a typo. Narrow upper arch, then broad lower arch. It means the upper arch is a bit narrow or a bit smaller compared to the lower mandible, which is broad mandible or long mandible. Then the crowding is more common in the upper arch because the upper arch is more narrow, it's smaller. Then usually have a well-aligned or even spaced lower arch because the lower arch of mandible is a bit longer or bigger. So what is the features of castry malocclusion? So they can have a castry molar relationship with the angle calcification. Then anterior crossbite, or this is an incisor. Either the edge bite or the posterior crossbite sometimes it happens. Then upper arch is narrow and short. This one we discussed before. Usually the upper arch is crowded because the upper arch is more narrow and shorter. Then lower arch is broad. Sometimes they have the space on the lower arch. So upper arch mainly crowded, then space in the lower arch. Then they have this concave profile. Concave profile, it means they see the patient from the sideway. Then you look at this facial profile, they are a bit concave. So class 2 usually convex, then class 3 usually concave. Then class 1 usually have a straight profile. Then they usually have this prominent chin, which is a longer lower jaw. Due to the longer lower jaw, that's why the chin has been prominent on the lower. Then they usually have this vertical growth pattern. That's usually due to the patient breathe through the mouth. Then in long term, the face vertical height increase. Then anterior open bite can happen, or sometimes patient have a deep over bite. Some instances, so it can be open bite or deep bite, can be normal bite. Depends on vertical height of the face. So what is the extraoral castry features? So they usually have a straight or slightly concave profile and the anteriorly divergent profile. It means they have a high FMPL or frontomandibular plane. So look at this anterior divergent profile. It means that they have this lower jaw which is too long. We call it anteriorly divergent profile. So long face is very common features for the castry skeletal. Then extraoral profile, then photograph typical castry patient. So you can see the skeletal profile is slightly concave. Then extraoral frontal photograph or typical castry patient. Then usually have a long face, then a bit prominent chin. So intraorally, then patient have the lower incisor more labially placed than the upper. It means that we should have an anterior reverse overjet, or they have an anterior crossbite. Then they have a bit narrow upper arch because the upper arch is narrow. That's why I have a crowding on the upper arch. Then usually the lower arch is a bit longer and bigger or wider. Then that's why they have the spacing of well-aligned lower arch. Then when the upper is a bit narrow, then lower is a bit broader, then they usually have a buccal crossbite. It means the bite can be reversed on the posterior side, not only anterior side. So the severity of the class 3, we look at it, the extent of the crossbite can be anterior or posterior, can be the total arch in crossbite. That depends the severity of the jaw. The longer, the broader the lower jaw, the crossbite may extend from the anterior to the posterior. So this one, I think we talk about this many times. The castry malocclusion usually means the incisor, lower incisor edge, like anterior to the cingulum pectoral of the upper incisor, or the upper 1/3, the anterior to the upper 1/3 of the upper incisor. So this one is the palatal surface of the upper incisor, palatal 1/3. This is called cingulum pectoral. Then lower incisor, if they occlude anterior or in front of this middle third, you consider castry. So most of the time they either have the edge-to-edge incisor relationship or slightly reverse overjet or crossbite. So this one also we talk about it many times. This one is a class 3, molar relationship or angle classification. This means class 3 is a mesial buccal cups of the upper first molar occlude distal to the mesial buccal groove of the lower 6. first molar. So this one is illustrate the line of the mesial cup and occlude distally of the mesial groove. We call it cut 3. So now we come to this pseudo or habitual cut 3. So a typical cut 3 malocclusion referred to the pseudo cut 3 malocclusion is characterized by the presence of the occlusor prematurely, resulting in a habitual forward positioning of the mandible. It just means patient have the initial contact on the incisor usually, then the jaw will slide forward. So this one considered displacement or functional shift. This is what we call the pseudo habitual cut 3 malocclusion. It means initially the patient doesn't have this skeletal cut 3, the severe skeletal cut 3, but due to this incisor premature contact, and that's why the jaw slide forward. That's considered pseudo cut 3. Means they are not that severe cut 3, but because of the incisor and the displacement, they make it more cut 3. So this patient usually exhibit a forward puff closure. Means they usually glide the jaw forward. That may be able to bite edge to edge incisor, but the mandible will slide forward, considered a functional shift. So this kind of patient is easier to treat compared to the true skeletal cut 3, which is more severe or difficult to treat. So skeletal features of cut 3 malocclusion can be due to necrotic of the maxilla. It means maxilla is a bit too short. Or it can be due to the pronatic mandible, which is mandible is too long, mandibular excess, or combination of both, maxilla too short or mandible too long. So how we diagnose? Then we should determine whether the skeletal or dental, whether they are true skeletal or true cut 3 or pseudo cut 3. Pseudo cut 3, like I said before, they have initial contact on the incisor mainly, and the jaw will slide forward. They consider pseudo cut 3. So clinical examination should include the observation of puff closure. So when you see the patient have an anterior, posterior, any crossbite, the first thing you should check is whether the patient have the premature contact or the initial contact or any other teeth. Then do they have any puff closure deviations? Means the jaw will deviate to the left, right, front, sometimes the backward as well. They call it functional shift. So first thing you see the crossbite, and the second thing, maybe you should check any displacement or deviation of the puff closure. And maybe after you diagnose the cut 3, then you should take a study model and radiograph, like we said before, history, then clinical examination. Then maybe you should take some record, which is a study model, photograph, and radiograph before you come up with the final plan for the patients. Then lateral ceph is also available information of the skeletal nature of the malocclusion. So lateral ceph means you take the skull X-ray from the side, and this one will show you the skeletal severity, whether they are mild, moderate, or severe cut 3, based on this lateral ceph. So the lateral ceph not only measure the upper jaw, but the lower jaw length and the incisor angle as well. So you know whether the patient have this standard alveolar compensation. So what's the treatment of these cut 3 malocclusions? So the treatment planning, then the factors to be considered when planning the treatment for this cut 3 malocclusion is a patient opinion and concern, whether the patient concerned with the face or not. So let's say for mild cut 3, the jaw is slightly longer. Let's say patient doesn't care about that. They are happy, they can accept the skeletal pattern. Then maybe we just do braces to straighten the teeth. Of course, the result won't be perfect, but it's acceptable. So patient opinion, we have to take into considerations. So the first thing you should ask a patient, what is their concern? Whether they're not happy with the face, or they're not happy with the teeth, or maybe both. So the occlusion and facial appearance you take into considerations. So patient will tell you sometimes they are maybe a bit shy to tell you they are not happy with the face in front of the parents, but you have to ask them be very honest and be very frank what they're not happy with. Because at the end, they are the ones going to bear with the result, not the parents. So the severity of the skeletal pattern, so we have to look at the skeletal pattern anterior posteriorly and vertically. I mean, patient have the longer jaw, lower jaw, or shorter upper jaw, and sometimes they have some vertical access. Means the lower jaw or lower face a bit longer than the upper face. Then the amount and expected pattern of the future growth. So sometimes if the jaw is still growing, then maybe we can do more for braces. We can restrict the mandibular growth, and maybe we can promote the upper maxilla growth. So sometimes we can use some headgear, reversible headgear, to bring the maxilla forward, and at the same time can restrict the mandibular growth when the patient is still growing. But if the patient is not growing, then there's quite limited how much you can do for the gastric malocclusion. So the amount and expected pattern of future growth. So these I have to take into consideration. So in general, I think you have to remember that mandible usually grow a bit more than the maxilla, which means the class 2 maybe have the chance to become less class 2, but class 3 they always become more class 3 because the mandible will grow more than the maxilla. So the amount and expected pattern of growth, then generally the mandible will grow more than the maxilla. Then can the patient achieve the edge-to-edge incisor contact? It just means that can the patient bring the incisor together? So if you see the patient in the reverse spine or cross spine anteriorly, then you ask the patient try to bring the upper incisor and the lower incisor edge-to-edge. If they're possible to do that, then maybe the patient is a pseudo class 3, which is due to the incisor contact, then the mandible slide forward. This kind of patient, the prognosis is good compared to a patient who cannot achieve the edge-to-edge incisor. That's considered quite severe or moderate class 3. That's more difficult to treat. So the overbite also can be an issue. So let's say patient have the anterior open bite. It doesn't have any overlapping between the upper and lower incisor. Then maybe after you correct the class 3, it won't be stable. So we know the cross-bite corrections. So you have to have a stable upward jet and overbite in order to maintain the result. And sometimes if the bite is too deep, you might not be able to jump over the bite that easily. So the overbite have to take into consideration whether that deep bite or anterior open bite. So the amount of tender alveolar compensation present. So this one also means how much the upper incisor proclination and how much a recognition of the lower incisor already present. So like we said before, when the patient try to achieve the anterior oral seal or the competency of the lips, then usually they tend to retrocline the lower incisor and procline the upper incisor. So this is called the tender alveolar compensation. So let's say the upper incisor is already procline a lot, and maybe it's not good to procline any further. And same for the lower incisor. Let's say it's already retrocline a lot, and maybe it's not wise to retrocline the lower incisor further. So the amount of tender alveolar compensation also determines the treatment plan. And the degree of crowding, of course, for braces, let's say not enough space for alignment, quite straightforward, we take out some good teeth to generate the space for the alignment. So the degree of crowding also affects our treatment plan. So when and why to treat? So you have to recommend at the early age, so we can do something to modify the growth, and make it possible to intercept the abnormal skeletal pattern and to reduce the severity of developing malocclusion. So you can identify the malocclusion earlier, then you can plan for it better. So you can do something to make it less severe. So for the class 3 malocclusion, it's characterized by the anterior crossbite, resulting in retarded maxillary growth due to the locking of the maxilla meeting the mandible. So let's say if the crossbite is due to the premature contact, then the mandible slide forward. That's why they lock the lower jaw forward. This kind of patient you should try to treat early. So you have to get rid of this premature contact and try to bring the lower incisor backward, correct the crossbite, and hopefully the jaw will grow into the better position. So the occlusal forces on the mandibular incisor exerted by the maxillary incisor in the crossbite encourage the continued forward growth of the mandible, further worsening of this prenormalcy. So it just means that the lower incisor, because they are locked forward, and the jaw will continue growing into the forward direction. So if you correct the incisor relationship, so let's say crossbite, you reverse it and become the normal overbite overjet, then hopefully the maxilla and the mandible can grow together rather than the lower mandible will lock forward. So what's the interception we can do during growth? Let's say the patient is still growing, then there's a lot of options we can do. Gastric malocclusion with an underlying skeletal malrelationship require early treatment to intercept the developing skeletal malocclusion. So the growth modulation procedure, we can do so many appliances. So the first one is a flanker of 3 appliance. Then you can do reverse activator. chin cup with a high pull headgear, then reverse twin block, then castrate bionatal, reverse headgear with maxillary intrusion splint. So this one I call it jaw modification devices. So early orthopedic treatment. So orthopedic, it means involve the bone. We can try to correct the skeletal castry when they're still early or young age. So orthopedic correction aims to enhance or encourage the maxillary growth. So we already talked about this, the maxilla is too short, so you try to make it longer. At the same time, the mandible is too long, they try to restrain or redirect the mandibular growth. So success rate is good if the treatment is carried out prior to pubertal growth spurt. So with pubertal growth spurt for girls, we are talking about 11 to 13 years old, and for boys about 12 to 14 years old, plus minus 3 years. So when you do it during this growth spurt or before growth spurt, then you get the maximum result. But if you do it after the growth spurt, then usually the treatment outcome is not that favorable. So correction can be achieved by protection face mask. It means you try to bring the upper jaw forward using this protraction face mask. Then we can do some bone ankle maxillary protections. Then I can do a big combination of all the treatment, which is chin cup, sometimes the protection face mask, or sometimes we can do some 3D screw. We can talk about this one by one with the pictures. So protection face mask, it just means you're wearing the face mask attached the forehead and the chin as an ankle, and you use a rubber band attached to the maxilla. And hopefully this one can drag or bring the maxilla forward. If the patient wear this full time or maybe half day, about 12 to 16 hours, then this maxilla can bring forward. But this one, you need a compliance from the patients. It's not easy because they're wearing this face mask. Sometimes we call it Terminator face mask. It can be quite ugly, quite obvious, then patient don't like it. Then this face mask usually create a high force from the rubber band, which hopefully can bring the maxilla forward. But patient need to wear it almost half day or more than half day. So basically, when they come back from school, you have to put the face mask on. So this one is a very powerful device. So if you wear it well, yeah, it can restrict the mandible and at the same time can bring the maxilla forward. Then the second one is bone anchoring maxillary protections. It just means they put some screw and plate on the maxilla and mandible. Then again, same thing, they attach a rubber band. This one I call it castry rubber band. Then attach from the maxilla, the back of the maxilla, then to the front of the mandible. Then they're pulling each other. Then hopefully you can reverse the bite and at the same time can protract the maxilla and at the same time you restrict the mandibular growth. But this one need a surgery. You need a surgery to put it on. Then after treatment, you might do another minor oil surgery to remove the plate and screw. So we're talking about 2 times surgery. So chin cup, it just means they put something on the chin. Chin cup has the effect of rotating the mandible downward and backward with a reduction of the overbite. So the chin cup, it just means they put a cup to attach to the chin, then use the ankle from the skull, and hopefully they can restrict the growth of the mandible. But from the research, it showed that what this device do is they will rotate the mandible backward. See the direction of pulling. They're not only pulling the maxilla back, mandible back, at the same time they also rotate the mandible backward. So when you rotate the mandible backward, then you make it less castry. So imagine this jaw grow backward, rotate backward, and the patient become less castry. So 3D screw, it's just meant to expand the upper maxilla. So it's capable to expand the maxilla in the 3D directions. So what they do is put the removable, and they have a 2 screw, one for the anterior, one for the posterior. So when you turn the screw, they will expand the upper jaw in the 3D directions, anterior and posteriorly. So the 3D screw incorporate in the removable appliance. Sometimes you can do in the fixed appliance or sometimes you can do in the removable. In this picture, it just shows that it's a removable. So there are 2 screws. Every time you turn the screw, they tend to expand the jaw about 0.25. Every turn is about 0.25. So this screw, when you turn anteriorly and posteriorly, they will expand the jaw, mainly upper maxilla. So sometimes we can do a simple device which anterior biplane. We call it lower anterior inclined biplane. Then this one can reverse the crossbite. So provided the crossbite is not too severe, then removable appliance incorporating the screw for anterior expansion. So this one is the same thing for anterior expansion. This one inclined bite plane, they have for about 45 to 60 degree. The inclined bite plane is about 60 degree. And whenever the patient bite, they tend to slide the incisor forward. So imagine if the upper incisor, they bite on this bite plane, they will slide forward. That's how we correct the crossbite. So treatment for the posterior crossbite can be treated by this rapid maxillary expansion. So just now we talked about this expander is removable. Then we can have a second option, which is a fixed expander. So this rapid, right, is a name says rapid maxillary expansion. It means to expand the jaw in a fast rate. So compared to this removable, you have to turn it maybe once a week. Then every turn is about 0.25. Compared to this fixed, they also turn the screw once a day, not once a week. This one once a day. Then every turn is about 0.25. So if you turn it every day, in 1 week, you can achieve maybe 3 to 4 millimeters. So which is quite powerful. So what's the role of extractions? So when we come to a mild to moderate class 3 malocclusion, then maybe you can do the camouflage treatment. It means using only braces treatment only without the surgery. So class 3 malocclusion characterized by the porcine upper incisor and the upright lower incisor. Then maybe you can do some camouflage treatment. So lower arch length deficiency and the anterior crossbite can be treated by extraction the lowest first premolar. So imagine if you take out the lowest first premolar, then you can bring lower incisor back with the space you created by the extractions. And of course, you can do some class 3 intermaxillary elastic, should be used to retract the lower incisor. So you can attach a rubber band from the back of the maxilla, then to the front surface or the front tip of the mandible. Then there are reciprocal forces, which is pulling the upper maxilla forward, and then lower mandible backward. So by doing that, you can reverse the crossbite or correct this class 3 malocclusion. But if the arch length deficiency involves both the arches, then the first premolar should be extracted in both the upper and lower arches. So let's say the upper jaw is too crowded, then maybe you have to extract the upper arch as well. So not only the lower. If the upper arch is well aligned, only the lower is in the reverse spike, maybe extract the lower. But if the upper also crowded, maybe extract the upper and lower premolars. So orthodontic camouflage, it just means the correction of the class 3 malocclusion with only braces approach. Orthodontic correction of class 3 malocclusion relationship can be achieved by proclination of the upper incisor. So when you procline or you push the incisor forward, upper incisor forward, it reduces the overbite. But if you retrocline the lower incisor, it increases the overbite. So this one, I think you have to try to imagine. If the upper incisor push forward, then usually there will become a bit less overbite. Then compared to the lower incisor, let's say retrocline the lower incisor, they become a bit deeper bite. So can we do both combinations? It means you procline the upper incisor, then retrocline the lower incisor. By doing that, they counter the effect of each other. So you still get the normal bite. So a lot of time for the camouflage treatment, for braces, we always procline the upper incisor and retrocline the incisor, which means the patient will still remain skeletal class 3, but the incisor angle will change. That's how we do the camouflage treatment. By changing the incisor angle, we correct the overbite, overjet, but the patient's skeletal pattern still remains class 3. So this one you have to remember very clearly. Class 3 camouflage treatment using braces only. We are not changing the skeletal. What we do is changing the teeth alignment or position or angulation. By doing that, we give you the false impressions. We correct the class 3 skeletal. But in fact, we are changing the incisor angle, not the skeletal. So correction of crowding, simple. So let's say not enough space, maybe you extract. So space for relief of the crowding in the upper arch can do by expansion. So if you expand the upper arch anteriorly, then you can correct the incisor relationship. And buccolingual, then you can correct the buccolingual crossbite. But when you come to severe crowding, sometimes expansion not enough, then we take out teeth. So when we come to severe case for skeletal castry, then maybe we have to consider surgery. So the severity of the skeletal pattern determines what is the treatment, best treatment option for the patients. So when we come to orthodontic surgery, it means the patient is not growing, usually for adult patients, when we reduce overbite and anterior open bite. So like we say before, if a patient have an anterior open bite, even if you correct the castry malocclusion, it won't be stable. You need the positive overbite and overjet in order to hold the result. So when it comes to anterior open bite, non-growing patient, which is adult patient, and there's quite limited what we can do for this kind of patient. And we usually consider orthodontic surgery. So when it comes to orthodontic surgery, then you have to determine whether the upper jaw is a problem or lower jaw is a problem, or maybe can be both jaw is a problem. So when it comes to only the mandible is a problem, then we can do maybe just surgery to shorten the lower jaw, which means a BSSO or bilateral surgical split osteotomy. So basically, you just cut the lower jaw and push it backward, and then stabilize with a plate and screw. Of course, sometimes we can do the distraction osteogenesis, which is not very common nowadays. It means they put a distractor, then every time you turn the distractor, they will lengthen or shorten the jaw. So maxillary procedure, if the maxilla is too short, then maybe you can do anterior segmental osteotomy. It means you cut the upper jaw, then you move the upper jaw forward, downward, or any position you want. So you call it anterior segmental osteotomy. You can do the Edward 1 osteotomy, which involves the whole jaw. Then segmental, it means it's just a segment of the maybe maxilla, usually the front segment. So treatment of the severe castry after growth, means the patient is not growing, which is the adult patient, then it can be treated by surgical and corrective procedure. So maxillary advancement, level 1 osteotomy, and then the bottom one is the mandibular setback. It's just a picture to show you how we do it. So this one, maybe we have to do combination, I mean upper jaw forward and lower jaw backward. So if the lower jaw is too long, maybe you just do the lower jaw, then BSSO or mandibular setback. Okay, cases treated with bilateral surgical split osteotomy. Like we say, if the lower jaw is a problem, then maybe we just cut the lower jaw and bring it backward. So let's say his upper jaw is too short, then maybe you just do upper jaw. Then this one osteotomy, it means break the upper jaw and bring it forward. So if they are both upper jaw and lower jaw, maybe you can do level 1 and then plus a PSSO, combination of both. So this chart is just summarize what we say just now. So basically this castry malocclusion treatment divided into growing patient and non-growing patients. So growing patient, there's more we can do. Non-growing patient, there's a bit less we can do. So growing patient, then we subdivided into this skeletal castry and dental castry. Same with the non-growing patient, skeletal and dental. When it comes to dental castry malocclusion, they're usually a bit easier. We can do braces to treat or correct the malocclusion. When it comes to skeletal, then they are a bit more difficult to treat. If the growing patient, young patient, maybe you can do some jaw or growing modification devices. So if the maxilla is retrognathic, it means the maxilla is too short, then maybe you can do the face mask to protect the maxilla and move the maxilla forward. So if the mandible is too long and maxilla is too short, then maybe you can do combinations or all the appliances. If the mandible is too long, maybe we do the chin cups or to restrict the maxilla growth. Sorry, this one is the mandibular growth. So I think there's a typo here. So the chin cup is for the mandibular growth, restrict the mandibular growth. So just make a correction here. Then if they come to dental castry, then the only treatment is they're using the braces only. But if the non-growing patients, adult patient, when it comes to skeletal castry, then most of the time we have to do the surgery, either the maxilla, mandible, or combination of both. Or sometimes moderate, then maybe you can do braces only. When it comes to severe case, always surgery. So what's the summary of this castry malocclusion treatment plan? So to summarize, the planning of treatment can be categorized as treatment of the pre-adolescent child, means the patient is very young. Then we can use a face mask therapy or chin cup or maybe some screw to rectify it. So if the patient is growing adolescent, which is teenagers, Then maybe orthodontic camouflage or orthodontic recompensation in an effort to prepare the patient for surgery. So sometimes when we see the child or the teenagers, they have this severe castry malocclusion or the skeletal malocclusion, which is too severe to rectify by braces or knee, then maybe we will prepare the patient for surgery. So what's the earliest age we can do braces for this kind of patient? Then usually we do it when patient is 16 years old. Then we do braces about 2 years just to prepare the patient for surgery. When the patient is 18 years old, it's just nice age, which is a patient is stopped growing, then we send the patient for surgery. Then after the surgery, we have to continue treating the patient to tidy up the occlusion for another 6 months to a year. So for these orthodontic patients, then usually we treat the patient about 3 to 4 years. That's the surgery will get delayed quite a lot sometimes due to the waiting list for the surgery. So for orthodontic treatment, a bit shorter. For orthodontic patients, then combination of surgery and braces together, then usually take a bit longer. When we come to treatment during adulthood, let's say they are already past 20 years old or past 18 years old, they're not growing. They are quite similar to adolescent, but except we are more to surgical side for corrections. So I think with that, I finished my lecture today. Do you have any questions to ask me regarding this castry malocclusion? If not, we just go back to the learning outcome. So you should be able to explain the incisor and molar classification. So for incisor, we know the incisor age is biting on the single petal of the upper incisor, which is the palatal surface, 1/3 of the palatal surface. If they bite in front of this single petal, then it's considered castry. So last week, I think someone asked me about this cross bite. So if the cross bite or H bite, then it's still considered castry. So if the incisor is biting in front of this middle third, it's considered castry. Whether they are in front or totally in the reverse bite, it's still considered castry. Then the molar classification, it just means the upper 6, the mesial buccal cups is occlude posteriorly or distally of the mesial buccal groove of the lower first molar. This is an angle classification. So when I talk about malocclusion, they always refer to the incisor and molar. But like we discussed before, when we say castry malocclusion or castry malocclusion, mainly we refer to incisor rather than the molars. Because you can have a class 2 or class 3 incisor, but you have a class 1 molars or sometimes the molar is missing, then can be a problem. So when we refer to class 3, class 2, class 1, mainly for the incisor. So the etiology for the class 3 malocclusion, it can be mainly genetic. When it comes to skeletal class 3 or class 2, mainly genetic. Of course, we have some environmental factor, which is the soft tissue, the teeth, then this might come into consideration. But last week, we talked about this etiology mainly divided into dental, skeletal, soft tissue, and habit. So for class 3, maybe dental, maybe skeletal, or maybe a bit of soft tissue, but hardly is a habit. So because of finger biting or thumb sucking usually cause class 2, not class 3. So differentiate between the type of class 3 malocclusion. It can be true class 3 malocclusion, or it can be pseudo class 3. So we talk about this pseudo class 3, which means you have the incisor initial contact, then maybe the jaw will slide forward, or patient have a functional shift or displacement of the lower mandible. So this kind of patient, we call it pseudo class 3. So pseudo class 3 means the skeletal is not that severe. It's just because of the teeth, not able to bite in the stable position, and that's why the jaw slide forward, they make it more class 3. So this kind of patient, they are more easier to treat, and the result you should be more favorable compared to the true class 3. So it may come to true class 3, which is a moderate to severe skeletal class 3. Then this kind of patient, usually the best to deal with the surgical approach, which is orthodontic surgery, either their upper jaw or lower jaw, a combination of both. Explain the treatment approach of class 3 malocclusion at various stage of development. So first thing, we have to see the patient still growing or not. If the non-growing patient, then mainly either you do it with braces only, provided the skeletal is not too severe, or you do it with orthodontic surgery, only 2 approaches. But if you have a patient still growing, then maybe they are young, then maybe you can do some jaw modification approach devices. So maybe you can do face mask, protection face mask, or chin cup, or sometimes reverse pull headgear, or whatever jaw modification device if they're still growing. But if they're not growing or toward the end of growing, then maybe you have to consider the same approach. Either you use the braces, the camouflage, or you can go for surgical approach, which is orthodontic surgery, if the skeletal pattern is too severe. I think with that, I summarize all the lectures. Do you have any question to ask me regarding this class 3 malocclusion?
No, doctor.
No? All clear?
Okay, doctor.
Okay. So the class 3 is easy to identify. Maybe you can see people walking on the street, from the skeletal pattern or facial profile, they are class 3. But to treat the class 3 is a different thing. It's easy to identify, but difficult to treat. So next time, if you're going out from the dental school, you're starting braces or orthodontic treatment, then maybe class 3 patients, if it's too difficult, then my advice is to refer to the specialist orthodontist to let them deal with that. Because if you mess up, it's quite difficult to rectify the class 3 malocclusion. So I think maybe you have to be careful when it comes to the class 3 malocclusion. Class 2, I would say, a bit easier to treat compared to class 3. Because class 2, there are more things we can do compared to class 3. But the severe one, for both class 2 and class 3, you still have to do it with the surgery. So braces, there are always a limitation how much you can rectify the malocclusion. When it comes to mild and moderate, maybe braces only. When it comes to severe, then maybe it's best to deal with surgery. So class 1, no issue, because class 1, the jaw is not a problem. It's only the teeth and crowding. So if you start with the simple case, then always choose the class 1. And the class 2 and class 3, you do when you are expert. Okay, no questions? No question, then maybe I will end the lectures and I will see you next time for the tutorial. Then before the tutorial, maybe just go through the class 1, class 2, and class 3 malocclusion, then combine everything together. We'll go through some case scenario, maybe some pictures, then maybe you can plan the case together. Sounds good?
Yes, doctor.
Okay, all right. I'll see you next time then.
Thank
All
you.
right.
Thank you, doctor.
Thank you, doctor.
Sign attendance, huh?
Thank you, doctor.
Okay.